Okay, all right, wonderful. Thanks for the invitation. I do not have any disclosures. I'm going to have a few slides and we'll be quick and fast. There will be some medical terminologies. You can ask me questions at the end or you can ask them in the chat room. All right, can we go to the next slide? All right, dizziness. So 72% of migraine patients report dizziness in their lifetime. It's a very common symptom. It can be a bit vague for providers, so it's important to ask patients what specifically they mean by dizziness. Dizziness may have different meanings for different patients. So the first picture you see on the left, this is I hope this is not giving any dizziness to the audience here. This is a room spinning sensation patients describe, or the environment is spinning around them. Then the next common thing patients talk about is when they're walking in hallways or grocery stores or even driving, the trees on the side of the road, that becomes a fuzzy and causes them to be dizzy. Sensation of being off balance is another common presentation or explanation of dizziness. Then feeling of being on a boat, that is also something that patients describe with their headaches. Then lightheadedness, sweaty, clammy sensation. And then lastly, heartbeat, a funny heartbeat or heart skipping a beat. Those symptoms are also described as dizziness. All right, can we go to the next slide? All right, so these are the possibilities when patients walk into our clinic with migraine and dizziness. I'm going to go briefly because they themselves are a big topic. So vestibular migraines are a very specific type of migraines, and the dizziness is intrinsic to these migraines. This is classically a patient who has a prodrome or an aura of room spinning sensation for a few minutes, followed by a headache. If we look at the criteria for vestibular migraines, they actually don't even have to have headaches with this vestibular migraine. They can have this dizzy episode, they can have light sound sensitivity, they can have visual auras with this vertigo sensation, and they classify as vestibular migraine. Now, the important thing to note is that patients with the migraine, the dizziness, the separate causes of dizziness can coexist with migraine. All of these causes I mentioned below can exist in a migraine patient, so that itself can be a separate disease coexisting with migraine. Meniere's disease is typically described as ringing in the ears, transient hearing loss, can become permanent in a few years' time. These episodes of room spinning vertigo with headaches typically occurs for a few minutes. Sometimes the headaches can last for a few hours. Initially, it can be very confusing and can present similarly as a migraine, because migraine patients actually can also have ringing in the ears, room spinning vertigo. They sometimes temporarily can have hearing loss too. So I think having a audiometry for hearing testing is important to differentiate between the two. Then another common symptom, BPPV, benign peripheral positional vertigo, typically triggered by position change. The vestibular migraine, by the way, the dizziness in that migraine can also be triggered by position change. But BPPV symptoms are classic in a sense that patients develop sudden onset room spinning sensations with a change in position, and it peaks within a minute and then starts to die down. They can have multiple attacks during the day. They can go on for sometimes few days to weeks and then just die down. Vestibular neuritis is also a room spinning sensation most of the time. That is typically linked to some viral infection, preceding viral infection. It goes on for a week or two, and then it also dies down. There could be some sequelae, which I'm going to tell below, um, mentioned as persistent postural perceptual dizziness syndrome. Then heart arrhythmias, skipping heartbeat, atrial fibrillation, bradycardias, heart blocks, they can present with dizziness. Uh, POTS, postural orthostatic tachycardia syndrome, common in young females in teenage and early 20s. That is a symptom that is classically described as feeling lightheaded, feeling of passing out when standing up after lying flat for long periods of time. These patients typically have, when we check their blood pressure and pulse, blood pressures do not change significantly when we stand them up, but the pulse goes typically 30 points up the beats per minute. So, and then, if dizziness is unusual, atypical, persistent, not responding to conventional treatments, may have some other signs of normal neurological exam, then we scan these patients to find out if there's a tumor. In elderly patients with headaches and migraine, a common cause of dizziness could be a side effect of drugs. So the anticholinergic drugs are common. The antihistamines can paradoxically cause dizziness as well in some patients. Benign prostatic hyperplasia drugs, they can affect the blood pressure and they can cause dizziness. Some of the antidepressants are common causes of dizziness in elderly patients. Persistent postural perceptual dizziness is typically a diagnosis of exclusion. When all the above workup is done and it's negative, we have not been able to identify any cause of dizziness, then sometimes this diagnosis is given to patients to give them a closure that, this is a condition that exists. It's a persistent feeling of unsteadiness that can go on for months, sometimes even years. Lastly, mal-debarkment syndrome. Some of you might have heard. This is a phantom perception of motion, or in other words, a persistent seasickness. As the name says, this is a French term, and it used to be thought that it used to be solely linked to cases who would have come back from a cruise. But over the last few years, there have been cases reported with prolonged air travel and prolonged car rides, helicopter rides. So that is not listed here, but it's called mal-debarkment syndrome. In case you are interested, you can look it up. Can we go to the next slide? All right, so briefly, dizziness and migraine, the connection, the major symptom of dizziness is vertigo, meaning room spinning or sensation of patients spinning around the environment. So in some patients, it's thought that the trigeminal nerve is the main headache causing nerve. It's the main migraine nerve that causes headache. As you can see in this diagram on the right, the vestibulocochlear nerve, which takes this sensation from this vestibular system, a very delicate system, probably not even an inch or 2 inch in dimensions behind the ear, that senses balance. The vestibulocochlear nerve takes these sensations to the brain for perception of balance. And you can see how close they both live in this brainstem neighborhood. So some of these patients who have predominantly dizziness or vertigo with their migraines, and vice versa, having vertigo and having headaches. Some of these patients, they're thought to have a lot of inter-nerve connections between the two nerves, trigeminal and vestibular nerve, which is the dizzy nerve. So that's what scientists believe. That's why they're more prone to having dizziness with their headaches. All right, can we go to the next slide? All right, so these are some of the points here. I mentioned earlier, 72% of migraine patients report dizziness, and vestibular migraine prevalence is up to 10% of patients in population studies. Dizziness or vertigo constant vertigo can happen, and stroke is permanent damage to the brain. And despite that, even stroke-related vertigo is not lifelong. It's not permanent because the brain adapts to the new situation. So if it's permanent, if it's constant 24/7, then and the workup has been negative and it's going on for months or years, then some scientists believe that there may be some psychogenic component to this dizziness or vertigo. Now, in the modern clinical trials, the secondary outcomes, the primary outcome is headache relief or decrease in headache severity and frequency, but the secondary outcomes have been decrease in nausea, decrease in light sound sensitivity. Recently, based on my research, uh, looking into studies, this decrease in dizziness or effect of dizziness has not been reported as a secondary outcome. So it'd be interesting to know in the future clinical trials if, given that so many of these headache patients have dizziness, if someone could or researchers could look into this parameter as well, in addition to the light sensitivity, sound, and nausea. The good thing is that there are CGRP receptors. So theoretically speaking, the CGRP injectables, oral abortives, or IV CGRP drugs have a potential to help with dizziness too. The older studies have shown that the conventional migraine drugs have decreased dizziness in patients like the topiramate and the other tricyclics. All right. Now, the nystagmus, just as a general rule, I mean, things can vary too, but the torsional or the diagonal type of a nystagmus, meaning a rapid movement of the eyes, when we trigger those in putting patients in certain positions, is related to a benign positional vertigo. And the horizontal one is typically seen in Meniere's disease, the one I just talked about, where there's hearing loss is very prominent. And then migraine is a central nervous system problem coming deep from within the brain. So patients can have an upside down nystagmus. Next slide. Now, for our new headache patients, we have this specific question designed for dizziness. As you can see, dizziness can mean different things to different patients. So room spinning, is it a feeling of imbalance, lightheadedness when standing up? Is it cardiac in origin? Is there Meniere's disease? Skipping a heartbeat, warm, sweaty, clammy sensations, palpitations. All right, next slide. All right, so these are some of the bedside tests we could do or easily order. And they can be easily done in a neurologist office. So the first one is these blood pressures and pulse checking, lying patients flat for at least 5 minutes, then standing them up at least for a minute or two, and then checking their blood pressure and pulse. If there's a difference in heartbeat going up 30 points up, then we diagnose these patients as postural orthostatic tachycardia syndrome, POTS, which can coexist with migraine. In fact, I'm sure Lauren sees a lot of these patients with POTS and migraine in her clinic. So this is something that can be done easily. If patients click on the dizziness questionnaire, then we do these, then our nurses do these orthostatic vitals on them. Frenzel goggles I started using, it's been some time now. I had the opportunity to work with one of my colleagues at Hopkins, Dan Gold, who's a national known figure for dizziness treatment. So there they use this device very frequently. It's a very cheap device available. And what it does is that it removes the fixation of the brain on certain points. So then the nystagmus becomes more prominent. It also magnifies the eyes, as this you can see in this picture. There are certain tests we could do while patients are wearing these goggles to look for nystagmus, which is the eye shaking. The common one at bedside is the HINTS test, which is a head impulse test, and looking at the SKU. Apologize for using this medical jargon here, but I can answer questions if there's any ambiguity later on. Optokinetic nystagmus is also can be done with this special goggles. Um, then in the previous slide, I had mentioned the type of nystagmus: horizontal, vertical, or diagonal, or torsional, that can be picked up by putting patients in certain positions. The third one is this Holter monitoring. If patients mention to us that they have migraine and they also sometimes skip a heartbeat, or the heart sometimes feels heartbeat feels funny, in those cases, nowadays so easy to order Holter monitor and put it for 2 to 3 weeks and pick up those abnormal um, heartbeat uh, signals. All right, and next slide are some of the treatments for dizziness. So there can be an overlap of migraine treatments and the dizziness treatments, but sometimes we have to address them independently. Like I said before, the modern clinical trials, they do not keep dizziness as an outcome measure, secondary outcome measure, just like nausea, light, sound sensitivity. But the older studies on older medicines, they have shown that they're retrospective studies, so not large clinical trials, that these medicines can help both headaches and vestibular symptoms. The conventional migraine drugs, the topiramate, beta blockers, and antidepressant classes. Now, for specific vertigo type dizziness, we typically start with antihistamines, meclizine being the most common one. Um, Audiologists don't like meclizine because it interferes with their testing. It can suppress the nystagmus, which they're trying so hard to elicit during the dizziness testing maneuvers. Uh, and then if that fails, then we try benzodiazepines. Benzodiazepines are muscle relaxants. They are sleeping medicines, the most common used they're known for, but they also suppress the hyperactive vestibular system behind the ear. So they can be used intermittently, although we all know that they can be habit forming. But there have been times where I've had patients in their 60s and 70s, and they're miserable with these dizzy episodes, and give them a very low dose benzo, and their life is good. So um, then calcium channel blockers historically have been used in very small retrospective studies, show that they can help migraine with the patients with dizziness or vertigo. um, the venlafaxine or duloxetine drugs, which are in the SNRI category, they have been also tried, although we exactly don't know how they help in dizziness. Uh, Steroid bursts for a few days to try to break that cycle of acute dizzy spells has been helpful in some of the cases of vestibular neuritis coexisting in migraine patients. They're very small studies which show that triptans can help vestibular migraine as well, although they've not been validated by multiple studies, but triptans have been mentioned. So these are the drug treatments, and the best treatment overall, long term, is the vestibular rehab exercises. Um, Above in this picture, the therapist or the doctor is doing this Epley maneuver. I mean, nowadays on YouTube, there's so wonderful videos made by vestibular therapists on how to do Epley maneuvers at home. Although I still would like patients to at least have a one-time formal evaluation after the diagnosis of vertigo, and then they can do those at home. But gaze stabilization exercises, in my experience, have been great. The patients do it at home for 5-10 minutes every day. They fixate on a point, and this is sort of like adaptation for the brain, perceiving less of those stimuli, which I showed initially, walking in hallways or driving, and those trees on the side bothering them. And I mean, these exercises really don't have any side effects, so they're overall very helpful. Orthostatic dizziness, the POTS I mentioned, this is mainly based on conservative treatments for POTS, which is postural orthostatic tachycardia syndrome, coexisting with migraine. Lots of water, non-weight bearing exercises, rowing, swimming, recumbent bicycle. These are some of the common things we offer patients. I believe this was the last slide. Can we move to the next slide? Yeah, this was the last session. We can go one slide back.
Fantastic.
All right. Let me see if I have any questions on the chat.
The only thing is, would fullness in the head be categorized as dizziness?
No, this could be a symptom of migraine, or this could be one of the autonomic symptoms, but I wouldn't describe it as dizziness. Dizziness is a feeling of altered perception of environment or surrounding.
Okay, wonderful. Well, you gave us great information. And thank you so much for sharing. And as I said, I run 2 support groups, so I have some great information to share with some of the members. So I appreciate it. And if anybody else has questions, please put them in the chat. And when Dr. Wells is speaking, hopefully you can answer some of them. So we really appreciate it. And it was great to meet you.
All right. Thank you.
Thank you very much.